Well, you're very welcome to this talk. It's Monday the 15th of February. There's been quite a lot in the press recently about reinfection, so I want to look at that. And they are rare. Reinfections are rare, but they do occur. Are they going to be a problem in terms of herd immunity and global immunity and global spread of the pandemic? Probably not, but I think they are important to know about. Then we're going to look at some lessons to learn from a few countries around the world today. And then I want to finish off by looking at excess mortality. So if you take the actual number of people that have died of COVID-19 and the actual number of people that die more than a normal year, the excess mortality is greater than the number of people that die from COVID-19. And this is probably a more representative, valid way to look at the total amount of life lost as a result of this pandemic. So let's start off with this one, severe reinfection with South African SARS-CoV-2, and this does involve the 501st amino acid on this now infamous receptor binding domain of the spike protein. So Journal of Clinical Infectious Diseases, new publication about reinfections, it does say they're rare, albeit probably underestimated. Now I think it's fairly obvious they are underestimated because very often cases aren't officially diagnosed, let alone have a genomic analysis. So although reinfections are rare, almost certainly rare, they are underreported. So we don't actually know the real number of reinfections. Rare but underreported, I think, is a fair summary. So as of the 10th of February, only 31 confirmed cases worldwide. Now, this does require a diagnosis on the first infection, then a time when the patient's definitely clear, then it requires a re-diagnosis. So it's not surprising that they're rare. But the real number is higher, but how much higher, as I say, we don't really know at the moment. Anyway, in most cases, when there is reinfection, the reinfection is less severe than the initial infection. And this is very reassuring because the immunity from the first infection is going to make the second infection less serious. And in fact, most times it's going to be asymptomatic or minimally symptomatic. But there are the odd exceptions, which is really what we're looking at today. So in most cases, they're less severe. But this is about a case of SARS-CoV-2 infection with the South Africa variant, which involved the 501YV2 variation 2 mutation. So this South Africa variant that's caused all sorts of problems and caused quite draconian responses around the world because the threat is being recognised. Now, September, someone had a mild COVID-19 infection. No genomic sequencing were done, but they were given a positive antigen diagnosis. So there was a definite diagnosed case in this 58-year-old man in September 2020. So 58-year-old man. Now, he is immunocompromised, and this is really quite significant. People with competent immune systems are much less likely to suffer from symptomatic reinfections, and we know this from data that was collected in the northeast of England amongst healthcare professionals that we did look at. He also had a history of asthma, which we know is a high-risk comorbidity. And in December, he was tested twice. So diagnosed in September, tested twice in December. So pretty good follow-up on this individual. So that's a positive test followed by 2 negative tests. So we're pretty sure what ground we're on here. And in January 2021, that's 129 days after his first infection, he had recurrent difficulty in breathing, dyspnea, and he had a high temperature. He had fever. And this South Africa variant that he was diagnosed with had several mutations. Now, this is the 417th amino acid position, where the K amino acid had been replaced with an N amino acid. The 484th amino acid position on the spike protein, where the E had been replaced with the K amino acid. The N501Y, where the N had been replaced with a Y, and these are all in the receptor binding domain. And you now know that this is the part that actually clicks into the cell. It's the bit that actually forms the chemical bond. So that's the spike protein. It actually forms a chemical bond with this ACE2 receptor. That's how the virus clicks into, really. It's a process called adsorption, but it really is a clicking in. There's chemical changes and you get that bond. that connects the virus to the cell and allows the viral RNA to get into the cell and to do its worst, unfortunately, in the cell. So these are in the receptor binding domain, but there's 5 other, so that's 8. There's actually 8 mutations here, all in the spike protein of the virus. So this is why this seems to be causing this level of problem. So whether these probably occurred one at a time and accumulated, they probably all have a survival advantage for the virus. So 7 days later, this 58-year-old gentleman, severe acute respiratory distress syndrome, so his alveoli filled up with fluid, he got SAR, severe acute respiratory distress syndrome, or the acute respiratory distress syndrome as we sometimes call it. And he required intubation and mechanical ventilation the second time. So this is concerning, although it's just one case. South Africa variant not previously associated with more severe disease. So the South Africa variant is more transmissible. It's a bit like the UK variant and the Brazilian variant. It's more transmissible, but it's not documented as having more severe disease. So I suspect what happened in this case was that for some reason the individual's immune system had declined in the period of time between the first and the second infection. I don't think this is a characteristic of the virus, but I do think this is worth mentioning because a lot of people and a lot of press outlets around the world have become quite alarmed about it. And to be quite honest, although this is massively significant for the individual, I don't think this is necessarily what's going to become widespread in the future. But it's still vitally important, of course, that we don't get this South Africa variant. And we'll be seeing, for example, in the UK, we've had quite severe measures imposed today to try and prevent it coming in the country. So he was treated with dexamethasone, which is standard treatment, and tocilizumab. Tocilizumab is a monoclonal antibody. It doesn't combat the virus, though it reduces the body's own immunological inflammatory response. It's an anti-inflammatory drug. So it's working, it's an anti-inflammatory, the same as dexamethasone, it's just working in a different way, and both of them together work quite well. This is being commonly used throughout the health service at the moment, in addition to the dexamethasone. Antibody testing was positive for immunoglobulin against the SARS coronavirus 2. So, in other words, this patient had this problem, even though he still had the antibodies from his first infection. This shows that immunity does depend on several other factors, but I think what's happened in this case is because of his immunocompromise. Now, frustratingly, we're not told why he was immunocompromised. We are told it was not HIV. So, although the popular press has got hold of that, I do think it's a bit of a one-off, and although there can be reinfections, normally they will be asymptomatic or minimally symptomatic. So I kind of wanted to deal with that really, not because I think it's the way ahead, but I think it's kind of an exception that proves the norm really. It's an unusual case. So when you read about that in the popular press, and it is quite common in the popular press, I actually wouldn't worry about it too much, although we must never underestimate the importance of keeping these new mutations out until the vaccination program is well established. And we also know that manufacturers, the scientists that develop the vaccines prior to the manufacturing are working on more specific vaccines for these variants that will be out later in the year. Now, a few international stories that have caught my attention that illustrate things. Now, I'm not picking on Peru here, but in Peru, vaccines have been used, well, the very best you could say is inappropriately. What seems to have happened is a group of politicians got a very limited supply of vaccine into the country and started vaccinating themselves. Now, this has been reported in other countries. Now, I know I've had emails of concern from France and Germany that this could be happening, inappropriate vaccine prioritisation, even within the European Union, for reasons of localised corruption or even criminal reasons. So I'm not picking on Peru, but it's a problem that's going to rear its ugly head more and more as the vaccine programmes roll out, as long as supplies are limited. So what we know about this scandal in Peru, the foreign minister vaccinated last month. They've resigned. Health ministers resigned. These people have either accepted the vaccine themselves or have facilitated vaccination of their contacts. Now, I know when the vaccine first came out in the UK, quite a few of the UK politicians were desperate to get vaccinated because they wanted to, well, I'm sure they wanted vaccinated, but they did genuinely want to show that this vaccine was accepted by them, fully accepted by them. But they haven't. They've waited to get vaccinated in their priority groups. As far as we know, the only members of the royal family in the UK that have been vaccinated are like Her Majesty the Queen, the Duke of Edinburgh, because of their age group, and rightly so, they should be vaccinated according to their age group, the same as everyone else. It must be seen to be just, but the problem is in some areas it hasn't been. So I'm not getting at Peru. It's just one example. The reason I'm talking about Peru is it was reported on Al Jazeera, so I've got a reference for it. Early vaccination of other senior officials. This is just really quite disgraceful behaviour. We have an expression for this: cowardice in the face of the enemy. We vaccinate the vulnerable first. This has to be done in priority order. I mean, I could have been vaccinated I could have been vaccinated about 6 weeks ago, really, because of my health service connections. But I didn't. I'm waiting to be vaccinated in order for my age group and risk category. That means that there's a risk I'll catch this disease before that happens, and there's a small risk I'll die before that happens. But this is just the way it has to be done. In Peru, the hospitals are overwhelmed. Healthcare workers are getting prioritised, along with the over 75s, I believe. Now, from the healthcare workers are being vaccinated from the 8th of February, but in the country at the moment, there's only 300,000 doses. And the doses that the politicians received could have been given to the most vulnerable or to frontline healthcare workers, and yet this happened in Brazil. So in Peru, probably not Brazil, Peru. So other countries we could have mentioned, not picking on Peru, but it's a problem. This has to be done using law and order in priority. Now, Australia, Victoria, has had a rough time in this pandemic, relatively speaking, to other states in Australia anyway. 16 cases, and we believe they're all UK variant. Not good, more transmissible, big risk to Australia. Now, I haven't got a reference for this at the moment, but I've heard from email that the first vaccines have arrived in Australia. So remarkably good news. More on that as soon as I learn about it. But some people have emailed me to say vaccines have arrived in Australia. So that is good. The vaccination programme hopefully starting soon. But anyway, in the meantime, 16 cases of the UK variant. Now, make no mistake, 16 cases of the UK variant, if it were uncontrolled, is enough to infect 70 or 80% of the population of Australia. If it's uncontrolled, this is a major risk. Cluster, workers at a quarantine hotel, Melbourne Airport. So Melbourne went into a 5-day lockdown. Now, there's 2 new cases of locally transmitted infection. One in a 3-year-old. We assume he was just tested by antigen testing. We don't know that he's symptomatic. We don't think he is. So I'm expecting this 5-day lockdown, which I think finishes, I can't remember quite when. I think it might be Tuesday. I'm expecting that to be extended. So I would imagine that Melbourne will be in lockdown for another week or so, because it's so vital to not let the UK variant do to Australia what the UK variant has done to the UK. And I am optimistic they will be able to control this. I'm very confident they will be able to control this, but it will require these quite stringent measures for a period of time. And the authorities in Victoria and Australia have got a good track record of this, so I'm hoping they can do it. But the enemy is all the more dangerous now, because we know the enemy is 30, 40%, perhaps even more, 40% more transmissible, because it's the UK variant. Now, New Zealand, it's done so well. 3 unexplained cases in one family. Now, It's an airline. It's the mother apparently in this family is an airline catering laundry worker. So has she caught it from airline laundry? Quite possibly, because there has been no one infected in the community in New Zealand for her to catch it from. So there's now a 3-day lockdown in Auckland, and that's the first time for, I don't know, for ages and ages, because thankfully New Zealand was able to keep this out, as Australia was. Again, we don't have the genetics on the virus yet. We don't know what variant it is, but it looks like she got it from airline laundry. They're working on that hard in New Zealand, of course, but 3-day lockdown until they've assessed that situation in Auckland. So, I mean, the proactivity, of course, is excellent in Australia and New Zealand, unlike other countries that could be mentioned. Right. Japan. Oh, dear me. So Japan, having been presented with absolutely world-class data on the Pfizer-BioNTech vaccine, having been getting access to the US data, the UK data, the European data, the phase 3, the phase 1, 2, 3 clinical trial data, the Japanese government said, no, we don't accept that, we're going to do our own trial. And the trial they've done really is pathetic. I mean, I can't remember. We reported on this at the time, but it is a few hundred people in the trial. It was not enough to get any good stats out of at all. Anyway, they seem to have done that. They seem to have their fig leaf of national pride by doing their own trial, and they've approved the vaccine. We did, at the time, we said, look, Japanese authorities, take the data from the US, take the data from the UK, it's first class data. But no, they did their own little trial, and after they've done their own little trial, what do you know, they've approved it, as we said weeks and weeks and weeks ago. What a waste of time. So the vaccine rollout is starting next week, and the small sample size from the extra trial, as far as I can see, would contribute nothing to the scientific and epidemiological understanding. But I'm glad to see they have finally done it. They still believe they're going to have the Olympics in whenever it is it July? That's what they believe. Obviously, it's going to be impossible. I can't see any way that the Olympics are going to go ahead this summertime. But we will see. We will see. But it sounds like a completely unnecessary risk to me. Right, Germany, Angela Merkel, disappointment in the vaccine programme. Well, that's putting it mildly. It's been pathetic. The vaccine programme is going to be at full capacity by the end of March, beginning of April, according to the Chancellor. Let's hope she's right. She said they have to be smart in Germany to avoid a third wave, and the current lockdown finishes on March the 7th. I can't remember the percentage of the population vaccinated. I think they're given like 3 million vaccines or something. It's really not very much at all in Germany. And I know I've had some communication from Germany, quite a lot of communication from France. People there are furious at the slow administration of the vaccine. They're furious that the European Medicines Agency didn't get its act together quicker. And they're furious at the slow pace of vaccination, and understandably so. And they also have concerns that the vaccine is not being used in every part of the European community area according to priority groups. So let's hope that situation, I mean, end of March, April, it's still quite a long way off, in my view, the people of Germany have been let down, because they were ready and rearing to go on this a month before the vaccines became available. They had all the infrastructure available, but they insisted on going with the European protocol. Although, having said that, I think they've ordered an extra 30 million vaccines now on the side. That's not part of the European grand display of political unity. I'm trying not to make political points here, but my concern is that the people are not getting vaccinated quickly enough. And I think that's patently true. Right, UK 10-day hotel quarantine starts today. England is the list of 33 countries, and people going to Northern Ireland and Wales have to bounce off via England. I think that's the way it's working. Scotland, it's all international arrivals. It costs £1,750 for the first person, additional adults for £650 if they're sharing the same room, I guess. It's a lot of money. So for people that are entitled to come back to the UK, they have to pay £1,750. I mean, that's a lot of money. It's a lot of money to come home, or to come to England if you have the right. The UK, if you have the right to come here. And £650 for the extra adult. Of course, that means you've got to share a small hotel with them, You're supposed to stay in the room basically for all of the 10 days. So I think the best of friends would start getting on each other's nerves in that time. Anyway, that's starting today. And of course, it's all about keeping out these new variants, particularly the South African, but the Brazilian as well. Vaccination in the UK going well. Priority groups. So over 15 million first dose, second dose just over 500,000 going well. Public Health England now are starting group 5, which is all those aged 65 years of age and over. So the older age groups have already been offered a vaccine, which is excellent. So the 65 to 70-year-old age group's not that big a group. The next group 6, is going to take much longer to get through, because that's adults aged 16 to 65 in at-risk groups. So there's a big list of these people with increased. So these aren't people that are shielding. These are just people with heart disease and diabetes and things like that. So that's going to take a while to get through. But it's progressing. So, I mean, globally, I think Israel's out ahead. Then the United Arab Emirates in terms of population vaccination. Then I guess it's the UK next, and then probably the United States after that. So it's not too bad, but it still could have been so much quicker, to be quite honest. There's still been a lot of administration and bureaucracy. Is that unavoidable? It's unavoidable, but is it necessary is the question. I can think of ways it could have been done quicker, but it is the way it is. So, but still third best in the world so far, and again, European countries lagging quite a long way behind. Other European countries lagging quite a long way behind. Now, excess mortality reveals COVID-19 true toll in Russia. Now, this is an article published under the Journal from the Royal Statistical Society. So it's a very well researched article, otherwise I wouldn't have put this in. Do check it out for yourself. Now, basically what's happened here is this author has looked at the official death rates from Russia, like you get on international dashboards like John Hopkins. But then he's looked at a lot of other ways that mortality is reported in Russia. So there's quite a few different outlets, regional and national outlets, for mortality reporting in Russia. And he's done quite a lot of research and put all these together. And he's come up with some pretty interesting findings, really. Now, okay, this data only goes up to the end of 2020. So it's out of date, but it's what we have. It's what's been fully analysed. More up-to-date data, no doubt, will be coming out soon. So as of the 1st of January, Russia, 57,600 deaths. 0.04% of the population of Russia. And that's why we were looking at this yesterday. Now, yesterday, the deaths in the UK were 0.18% of the population, and the deaths in the United States were 0.14% of the population. So this is showing that the death rate in Russia is way, way lower than in the UK and the United States. This is way, way lower, indicating that the mortality in Russia is way less than the UK and the United States. Now, by way of comparison, again, on the 1st of January, while 0.04% of the Russian population died, in Peru it was 0.12%, Spain it was 0.11%, UK it was 0.11%, US it was 0.11%. So as I say, the UK has now gone on to 0.18% and the US 0.14%, as we looked at yesterday. And I'm not quite sure. Peru has had an awful time. I mean, just mentioned Peru there. Hospitals have been overwhelmed in Peru and Bolivia. So unfortunately, in these countries, there's been unnecessary deaths as well. Anyway, so they're the difference in the figures. So it looks like Russia's doing really well. Excess mortality in Russia from April to November, detailed data analysis was carried out. Now, the excess deaths during that time were 264,100 excess deaths. Estimates of excess mortality is 6.5 times the 40,000 deaths officially reported. That is in this time when the analysis was carried out from April to November. So that was the figure for excess deaths. That was the figure for COVID deaths. So it looks like the figure for COVID deaths, well, we know it's underreported, but the question is by how much? Now, so the excess deaths were 264,000. Now, that doesn't mean these were all COVID deaths, of course. These could have been what we might call knock-on effect or collateral damage deaths, to use that terrible term, of people that couldn't get treated in hospital for routine diseases which they could normally have been cured of because the hospitals were clogged up with COVID patients. But that is a massive, massive difference. And I think we do suspect that many of these patients were actual COVID diagnosed patients. Because to be officially counted on the statistics in Russia, the testing criteria are quite exacting. And that made the number of official COVID cases in Russia look much lower than the reality. So April to November, that was 0.18% of the country's population just in that time period had died. Ratio 6.5 of officially reported deaths to actual excess mortality. So looking like the number of deaths in Russia could be 6.5 times those actually reported. So quite a significant impact for the people in Russia. Daily reported death count for Russia, one of the least reliable indicators of epidemiological situation across all countries. Again, direct quote from the article. So basically, we haven't had good quality news from Russia. Now, we've looked at the other areas of the Russian experience where there is good quality news. For example, the Sputnik V vaccine, we've noticed had a 91.6% efficacy from what I remember and an excellent safety profile. And we know that because it was in, was it in the Lancet, that one? Anyway, it was in the peer-reviewed literature. We know that's, we believe that to be true. So you've got this sort of contradiction between excellent peer-reviewed material and things just not peer-reviewed. Now, by comparison, Anthony Fauci has always said that the official number of deaths in the US is a significant underestimate. So again, this is based on figures up till the end of 2020. So the excess deaths in the United States are about 1.3 times. So for every 1,000 deaths that are officially reported, there's actually 1,300 deaths in total mortality in the US, times 1.3. Mexico is believed to be 2.5. Italy is believed to be times 1.7. Again, this is the statisticians report. UK is believed to be 1.5 at the end of 2020. Spain 1.4. Iran 2.4. I would have thought it'd be higher in Iran, but that's what the Statistical Society are saying, so they're the experts. Germany 1.2, Poland 2.9, South Africa, the official, so it's more than double, 2.1. So I thought that was quite interesting. Russia, now, I worked this out on the 14th, so that's yesterday, isn't it? Population 144 million. Official death figure 78,825 according to Johns Hopkins yesterday. If that's multiplied by 6.5, if there's a valid multiplication, that means that the death rate in Russia is pretty well double the per capita death rate in the United Kingdom and the United States, with a total of 0.35% of the population possibly having died. We'll probably never know the exact figure, but I think we can certainly say that the per capita death rate in Russia is higher than the UK and higher than the United States. I think that is where the balance of probability is pointing. So let's hope that the Russian authorities are accelerating the rollout of their vaccine. And I believe people in Russia now are starting to accept that their vaccine is efficacious, is safe, as the peer-reviewed literature says, and are going to be more accepting of it. And I would hope for huge vaccination uptake in Russia over the next month or two, so that this death rate is no more. Okay, so that is us for today. Just a few things I thought were relevant, and thank you for watching and staying if you've stayed to the end.